Welcome to the Center for Health Affairs Board Education presentation, Is Inefficiency Ailing the Healthcare System? This presentation is based upon the Center for Health Affairs issue brief by the same title, which can be found on CHA's website, www.chanet.org. All issue briefs, as well as their corresponding PowerPoint presentations, are available on our website in the Publications section. This issue brief was originally released in September of 2004 and considers whether our nation uses the most efficient and effective means of helping people to have good health. Specifically, this issue brief takes a look at how healthcare financing, consumer behavior, and regulation have influenced the healthcare system, and the role these factors play in the system's ultimate ability to function efficiently. The financing structure that supports our healthcare system plays a role in fostering good health. As it stands, more resources are dedicated to treating diseases than to preventing them. This is true despite the fact that we know preventing disease is usually much less expensive than treating it. In 2001, we spent $1.2 trillion as a nation on personal health care services, as opposed to the $46.4 billion spent on government health activities. In addition to our focus on treatment rather than prevention, our healthcare system must also deal with a complex reimbursement structure. With Medicare, Medicaid, and private insurers all employing their own administrative and claim submission processes, the time spent navigating this system can be significant. In fact, the complexity of this system is a key source of the high administrative costs borne by hospitals. Nearly 1/4, or 24.3% of hospital expenses, are administrative. An efficient use of resources is one that provides treatment options in the most cost-effective environment, and yet our financing system does not always work that way. In Ohio, for example, Medicaid reimburses hospitals approximately 99 cents for every dollar of inpatient care provided, and only about 77 cents for every dollar of outpatient care, even though it is usually less expensive to provide care on an outpatient basis. Some inefficiencies are by design. Hospitals are engineered to handle peaks in usage rather than averages, ensuring that extra resources are available in case they are needed. Emergency rooms and trauma centers provide good examples. Even though there are times of day when there is lower level of activity in an emergency room, hospitals must make sure they are ready to exercise their full capabilities whenever necessary. At the same time, it is hard to know the number of patients or types of illnesses a hospital might encounter on a given day. While hospital administrators know that they are busier during flu season than during other times of the year, they cannot rely on assumptions that their volume in any given month will bear any resemblance to the volume in the same month during a previous year. When comparing the average number of inpatients checked into Northeast Ohio hospitals in January 2003 and January 2004, Northeast Ohio hospitals experienced swings ranging from 22% fewer patients to 60% more patients. Consumers today play an active role in healthcare. As in any other sector of the economy, entities involved in healthcare, hospitals, physicians, pharmaceutical companies, and others, compete for business. With consumers taking a more active role in healthcare today, it is not surprising that consumers' behavior has an impact on the healthcare system. Ongoing research and development is costly, but consumers demand it. U.S.-based pharmaceutical companies doubled what they spent on research and development between 1995 and 2002. These costs get pushed on to purchasers, which include hospitals, in the form of higher prices for pharmaceuticals. Another trait of consumers is that they often believe that the newer, more expensive treatment option is automatically superior, yet that is not always the case. A study of the National Institute of Health found that less costly diuretics used to treat hypertension were more effective than newer, more costly medications. Had the use of diuretics remained at the same level, antihypertensive prescriptions would have cost about $3.1 billion less between 1982 and 2002. The managed care story again demonstrates how consumers themselves shape healthcare delivery. Managed care evolved in the 1990s as a means of holding down healthcare costs by emphasizing wellness and controlling access to particular services, practitioners, and pharmaceuticals. Consumers did not like the idea of being limited in their choice of physician. There was also a backlash against insurers who refused to cover certain procedures or include certain pharmaceuticals in their formularies. As a result, favor with the concept of managed care has waned. Some argue that managed care plans did not thrive in part because there was no increased national emphasis placed on wellness and prevention programs. In addition, as employers shopped for the lowest cost insurer each year, and employees moved from insurer to insurer as they changed jobs with increasing frequency, insurers lost the incentive to make upfront investments in wellness and prevention that would eventually bring cost savings. Compounding these inefficiencies is the medical liability insurance environment. Despite the fact that medical care is getting better all the time, the incidence of medical malpractice lawsuits is also on the rise. Fear of being sued can result in the defensive practice of medicine or ordering overly precautious tests and treatments to guard against being sued. A survey of physicians by the Ohio State Medical Association found that more than 56% of physicians reported increasing the number of tests they order to protect themselves from potential liability. Regulatory oversight of healthcare providers is designed to protect both patients and employees and to ensure public funds are spent wisely. Yet despite their good intent, regulations have evolved into a complex web of red tape and paperwork. Given the 130,000 pages of Medicare and Medicaid rules and instructions, a significant amount of workforce cost is dedicated exclusively to following regulations. The result is that healthcare workers spend a great deal of time handling administrative requirements. For every hour of time spent treating an inpatient or surgical patient, staff spend an average of 36 minutes on paperwork. Regulations can also sometimes tie the hands of providers by not giving them the flexibility that they need. For example, Ohio was one of the last states to allow advanced practice nurses to prescribe medications. Once legislation passed giving APNs this authority, it was another 2 years as a result of requirements in the legislation before APNs could begin using their new prescriptive privilege. Other regulations that were designed to protect consumers had unintended consequences. The Health Information Privacy Law, part of the Health Insurance Portability and Accountability Act, places strict protections on health information. Clergy members in some parts of the country have had difficulty obtaining information about hospitalizations of their parishioners as a result of this law. Nearly every hospital activity is regulated in some respect by a dizzying array of federal, state, and local agencies. At the federal level, there are more than 30 government agencies that oversee some aspect of the healthcare delivery process. Less obvious examples of agencies that touch hospitals' operations include the Federal Aviation Administration, which regulates hospital helipads, the Occupational Safety and Health Administration, which provides a wide range of rules aimed at protecting workers, and the Environmental Protection Agency, which governs the disposal of medical waste and the use of hospital incinerators. Hospitals must also follow state regulations from organizations ranging from the Department of Health to Department of Job and Family Services. Localities also dictate their own set of regulations for hospitals, such as building codes. In addition to all of these government regulations, hospitals are also accountable to accrediting organizations, such as the Joint Commission on Accreditation of Healthcare Organizations and the American College of Surgeons Commission on Cancer. As you can see from this graphic depicting the many entities that have a hand in regulating hospitals, ensuring compliance with the many rules and regulations can be a time-consuming task. The bottom line is that simply following rules and regulation adds to the cost of providing services, and in many cases there are unexpected ramifications. For this reason, it is important to be sure rules and regulations are necessary and that their implementation is sensible and as efficient and economic as possible. Short of rebuilding the system from top to bottom, what can be done? Educating consumers in the cost of their care can make them better equipped and more responsible for controlling costs. Therefore, a good first step is involving customers in cost considerations. Using technology to streamline procedures can also create better efficiencies. In recent years, the American Hospital Association has made an effort to simplify the regulatory environment by engaging the U.S. Department of Health and Human Services in an initiative to eliminate unnecessary regulation and streamline wherever possible. As new regulations are developed, it is important to weigh their cost against their benefit and ensure that they are optimizing the healthcare system rather than bogging it down. Finally, we can invest in public health. While an investment in initiatives aimed at improving the general health of the population could require a significant outlay of funds at the start, the result would be a more efficient use of healthcare dollars and a healthier public. This concludes the Center for Health Affairs presentation, Is Inefficiency Ailing the Healthcare System? We hope you have found the information useful. Thank you.